sort of fits within the context of decentralized service delivery and the delivery of social protection programs. Just to kind of clarify terms or to situate us, so I'm talking mainly about PAN-PAM, and that's basically the government of Indonesia's national program for community empowerment. And there is an urban version and a rural version that operates nationally, basically in every village or sort of the urban equivalent throughout the country. And so for the rural program, we're talking 60,000 villages, which is quite large. And basically, sort of, you could sort of categorize the programs as community driven, and basically what that means is that a local body, typically at the village level, whether it's an elected council or sort of an implementation team that's selected through an open process, has basically the authority to decide how program resources are used and are responsible for sort of overseeing the use of those resources, project implementation, and sort of reporting back. So I hope this is relevant because in many sort of countries in the region, there are also CDD programs. I know the Philippines in particular has a very similar setup, both in terms of a CDD program that's moving to national scale, but also a large-scale conditional cash transfer program. So we can kind of potentially, if there's people from the Philippines in the room, maybe think about what would the lessons from that context be, and how could Indonesia and sort of the Philippines learn from one another. In terms of the overall context, sort of delivering services or social protection in a country like Indonesia is a huge challenge. It's a massive country. Sort of the result is that there's large variation in the quality and availability of basic services, particularly in sort of the more rural and remote areas. Prior to 98, I'd say prior to decentralization, there were large sort of top-down investments by government in, expanding access to basic services, whether it's placing a midwife in every village, constructing primary schools in every village, and which I think were quite successful. But since sort of the dual sort of political and economic crises, that context has changed a lot. And people typically refer to decentralization in Indonesia as taking place through a big bang. And so the laws in '99 and 2004 assigned a huge amount of responsibility, particularly in the delivery of basic services, to subnational governments, basically district governments and cities. And so I think now, sort of the recent figures is that 35% of national spending, or of the national expenditures, are made by subnational governments. So to answer the question whether or not local governments have a role to play in social protection, the answer is clearly yes. So again, we're in a context here where sort of those big push supply side investments were sort of derailed somewhat, where I think, if looking at the Vietnam case, for example, sort of the assignment of tasks at the different levels is still unfolding. So there's still a lot of uncertainty around, whether it's the flexibility to use fiscal transfers from the center by local governments. A lot of this is still pre-programmed, so local governments or schools and clinics don't have the flexibility to actually adapt or use those resources in a way they see fit to kind of overcome local challenges. There's huge, principal agent problems, basically. When you're talking about remote, large areas, it's impossible for local governments to kind of, monitor what's happening, how are the clinics performing, how are the schools performing. And so basically you end up in a situation where there's a lot of service delivery failures. You have high teacher absenteeism in remote schools. Recent surveys show it's around, up to 25%. A quarter of the villages throughout the country lack access to a midwife. The ratio of doctors, it's a ratio of 6 doctors per 100,000 people in rural areas, and 40% of those are shown to not be present during working hours. So big problems, and that matters a lot for the kind of the demand side investments in social protection, like conditional cash transfers. Conditionalities, they're the same targets that exist in the household-based program, but they're sort of they're worked on at a community level, because we're talking about sort of a block grant transfer to the village level. There's flexibility in sort of using that resource to address whatever people identify as the biggest constraint. If people aren't going to school because there's no teachers there, communities can contract a teacher. They can sort of organize, sort of remote classrooms or sort of mobile schools. If it is sort of income issues, communities can use the block grant to subsidize transportation or scholarships or the purchase of other types of education inputs. And it also uses this performance-based sort of model that is in sort of the household-based CCT, whereby communities get a larger block grant allocation based on a measurement of the relative performance towards meeting those health and education targets. I mean, so basically, Generosity was about a national program that had been ongoing since 1998, basically, and had been really successful in delivering rural infrastructure. But people were starting to find that the sort of the tertiary infrastructure was not the biggest problem, but the existing sort of program mechanism didn't lend itself to the type of investments in sort of smaller groups within a community that needed scholarships or needed a different type of support to access services. So this generosity model was really a way of trying to, how do you make this CDD platform accessible or more flexible or more responsive to the varied needs that people face in rural villages. So there's evidence that it worked. Some of the things that the evaluation found was that certain health and education outcomes improved, child malnutrition was 9.5% lower, et cetera, et cetera. People the program worked best in areas that were in sort of the bottom decile of service delivery. So where access to health and education services was the poorest, the program produced the best results. And it was also effective at communities were able to target program resources to the poorest, particularly like in-kind transfers. So I guess this program, it's compatible with the other social protection and service delivery programs that Indonesia is supporting. I mean, I think one of the reasons the program was successful is that it worked through existing systems that were out there. I mean, basically midwives worked longer hours in places where this program was operating. And I think because communities were able to pay them directly for services rendered. There are more health volunteers active in communities where this program was operating. Again, people could access the block grant resources to run local health activities. The facilitators in the program play this key linkage role. I think Vivialitas in the morning talked about the big sort of information asymmetries or the information problems that exist in rural areas. People don't know what programs are out there, what they're entitled to, how do they access them. So these facilitators are actually, they're able to get information and share this with rural community members. They're also able to involve sort of the technical people, the doctors, people working at the clinics, the teachers, in the types of activities that are designed and funded through the program to get more buy-in and get more of an interaction happening between rural villages and the frontline service providers. And again, it's using the same targets as the large household CCT. We saw a lot about the targeting this morning. I mean, I would just re-emphasize the sort of this community-based method. Basically, village government, communities, people were more satisfied with the outcomes, and that matters a lot in a context where it's really hard to differentiate between sort of the different levels of poverty, and you can create a lot of tension around that process. And so maintaining the social cohesion is a big priority for local governments, particularly village governments, and as sort of Indonesia is moving towards the mainstreaming of the use of the unified database for scholarships, for cash transfers, for all the other sort of the household-based programs, you'll get gains in efficiency, but you'll be sort of local governments lose out on one of the the few ways that they had to kind of to promote social cohesion locally. So that cost benefit needs to be. So this is going back to the targeting experiments, where I looked at the proxy needs test versus the community-based model versus the hybrid model versus self-targeting, and had really interesting results. ROSCIN is the Rice for the Poor program. It's one of the large household-based sort of social protection transfer programs, and I think Vivi Tess had mentioned that in 500 villages or so, Tampei is actually trying this method where they allow communities to, or they ask communities to kind of correct the lists. So the point there is that there's a lot of really good evidence around why it makes sense to kind of use these community-based targeting models, either in together with the PMT or similar models, but there's been little policy uptake, or it's been really hard to kind of get the buy-in more broadly. So in terms of what Indonesia is doing in its poverty reduction strategy right now is the three cluster framework. I think there's actually a fourth cluster, but you have the household-based social protection, the community empowerment programs, which is PAN-PM and related programs, and small and medium enterprise development. The fourth one, I forget what it is, but we have Tampei here. I'm sure they can enlighten us. Now, in terms of moving forward, you have the MP3KI, or the sort of the master plan for poverty reduction and social inclusion, which is in the early stages of being developed, but talks about it wants to get this consolidation of the social protection programs from 8 or so into one system. Another part is about improving the quality of basic services, or access to basic services for the poor and vulnerable, and working on sustainable livelihoods. Then there's what's called the PAN-PAM roadmap, which is trying to set the stage for what's community empowerment, what are these programs going to be for Indonesia in 2014 onwards. Is it still going to be part of poverty reduction in Indonesia, or is the role evolving? And again, a key element of that roadmap document is convergence, or sort of the integration of multiple programs into a single platform or a single set of facilitation. The details are still being worked out, but there's a little kind of a slogan behind it. You have one village, you have one development plan supported by one team or set of facilitators, and that's all about the idea that people or facilitators or villages can know what resources are coming into the village, how they can be used, and how that can sort of map onto priorities that have been identified locally. What's next? I mean, I think a key part that sort of practitioners, academics, we can help government as it works on this convergence agenda, is that if you get these different types of interventions sort of working together in an optimal way, you'll get sort of larger impacts. You also need this, again, along a similar line, is this a new supply side push. And again, calibrating supply and demand. I mean, again, the reiterating the message that came this morning, but a top-down supply-side push, I don't think it's going to work in this decentralized context. I mean, there's analysis, there's evidence that shows that increased expenditures by local governments in health and education service delivery does not correlate with better outcomes. In fact, there's some warning signs that certain outcomes are stagnating or getting worse. So what does the new sort of all the rhetoric, or if you're in the World Bank, you hear a lot about the science of delivery, but what does that mean for a context like this? I mean, do you need to work? Do you need to move towards something like service delivery units that are based locally, that are working with local governments to overcome these coordination failures that really sort of hold back service delivery? Potentially stop there. I mean, another point is, I think, as sort of decentralization is sorting itself out and sort of the roles and responsibilities are being clarified, local governments get sort of better at using resources and delivering services, that's going to take a while, and you're still going to need this investment directly in communities. Communities have been picking up a lot of the slack for years now, whether it's through community health volunteers. You see a lot more on sort of preschool and early childhood education volunteers. Now, of course, there's limitations to that, but I think with broader contextual changes, for example, there's a new village law that's being developed here that will potentially be linked with a large transfer from national government budget to village government budgets, and so would that be an asset that communities could tap into to run, community health activities and so on. So yeah, as it's going to be a bit of muddling through as decentralization takes place. You need this continued investment in communities, but ideally sort of linked up with this new models of delivery, new models of learning and evaluation, but also met on on supply side investments as well. So I think I will I'll stop there.
Great, thanks, Rob. Rob, do you mind going back to the slide with the questions in the beginning, the framing questions, just to leave those up there for now?
Sure.